So very good afternoon to all the esteemed dignitaries, guests, and attendees present here with us today. On behalf of Nationwide Quality of Care Network, I, Dr. Ashna, welcome you all to the launch event of the first issue of the BMJ Open Quality South Asia edition, where we will be witnessing the live unveiling of the QI stories from the field. We'll begin with the holy chanting of the Saraswati Vandana.
नमोस्तुते सरस्वती त्रिशूलचक्रधारिणी सितम्बरावृहे शुभे मृगेन्द्रपीठसंस्थिते त्वमेव विश्वधारिणि त्वमेव विश्वकारिणि त्वमेव सर्वकारिणि नमोऽस्तु ते सरस्वती 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 नमोऽस्तु ते सरस्वती
So these are the sessions that are planned for the event today. And without further ado, we'll be beginning with the sessions. So first of all, we have with us Dr. Subita Ghosh ma'am, who is Additional Commissioner in charge for Child Health, Adolescent Health, Safe Abortion Services and Aspirational District Program at Ministry of Health and Family Welfare, Government of India. We welcome you, ma'am. Ma'am is a pediatrician by education and has more than 35 years of experience in clinical training and administration in the government. She has previously looked after several programs like Family Planning Program, Maternal Death Surveillance and Review Program, and various other training programs in the Ministry of Health and Family Welfare. I request you to briefly share your perspective on the role of QI in delivering high quality MNH care during COVID-19, the Ministry of Health and Family Welfare perspective. Over to you, ma'am.
Thank you. Good afternoon to all the dignitaries who are present here today. Especially I can see Dr. Vikram here, Dr. Peter here. I can see Dr. Nina Raina here. I think Luigi is here. All of you, Dr. Sushil is here. All of you, a very good afternoon from Health Ministry. Ministry is having a very busy schedule now because of the parliament on and because of the the massive strengthening that is happening in pediatric care, COVID care all across the country. So please excuse my breaking the queue. I would like to say that quality, as we know, it's a single word, but there is a multiplex of complex interplay behind it, and it is really a lot of issues behind that single word, and which is very vital because the coverage, the access is not enough. Access to healthcare services is not enough. Unless it is supported by quality, we cannot make any dent either in mortality or morbidity. So that issue remains, and Government of India is very, very much into it, quality, assuring quality. And for pediatric care, which I look after, again we are going into another ensuring quality through our programmings like Suman, which is an assured service for mothers and children units and children up to 1 year. And we are going into a special pediatric oriented service, that is the Muskan. We have named it very aptly Muskan, to bring the smile on the faces of both the mothers and the babies and the families. So having said this, I am very thankful for making me the part of it. This this launch event of the first issue on BMG quality, open quality document, and I would extend my congratulations for this to NQOCN, UNICEF team, and WHO and others who have been behind it, because quality, as I said, it is a multiplex complex issues, and it involves many things starting from the leadership, but the equally it is important how at the point of care the quality is maintained. It involves having the governing system, the model of care system, the standards, the benchmarks, as well as the capacity, the infrastructure, so many other things, the participation and information, so documentation, so many things is there. And there are many models, but the best model is what have been done. So that it has been documented in this, and the best examples have been compiled. So I think this will be a very important tool in our hand, how to go about things, how to ensure how the best practices and innovations have helped quality improvement. So with these words, I would request that I may be, excused for I would have loved to be here. And the way forward is that we keep on collecting, documenting evidences on quality initiatives, because the contexts are different. For each facility, for each bedside, the quality issues are different. So what have been done and how it has been improved at various facilities, that is an eye opener, and we can take a lot of examples from it, and it may guide us. Thank you very much.
Thank you so much, Dr. Sumita Ghosh ma'am. I would request that before leaving, you virtually open the curtains and launch the BMJ Open Quality South Asia edition.
Thank you. I am privileged and very honored to inaugurate this open launch of BMJ Open Quality South Asia edition, which have been done by NQOCN and BMJ. Thank you very much.
Thank you so much, Dr. Ghosh ma'am, and a big round of applause, I think, from all the guests here. It's a great moment, ma'am, for the Southeast Asian teams for showcasing their work. And at the hands of Government of India and Professor Vinod Paul, who sent his message for this evening, because he is also tied up in a very important meeting right now in Niti Aayog, which will be subsequently read by me on behalf of sir. I had a communication with him in the morning. So thank you so much, ma'am. And we look forward to your continued support, like always, to all the endeavors. And at this point, I would like to mention the tremendous support. Dr. Neena Rana, ma'am, is here, and also Luigi is here, ma'am, as Chief of Health, UNICEF. That this issue would not have been possible without the tremendous support from UNICEF India and the field support from WHO CRO, ma'am, under the leadership of Dr. Anna, and the tremendous working experiences of teams across India, many of whom are going to be sharing their experiences. We will be sending you a recording of this proceedings, ma'am, for your ready reference. Thank you so much. Thank you for your presence, ma'am.
Thank you. Thank you very much. I wish today's program a great success and for future editions to come. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Moving forward, I would like to introduce Professor Vikram Datta, sir. Sir is Director Professor at Department of Neonatology, Lady Hardinge Medical College, New Delhi. He is the President of Nationwide Quality of Care Network and the Vice President-elect for 2022 for the National Neonatology Forum. And he is the guest editor for the BMJ Open Quality South Asia edition. Sir is also a member at the editorial board, International Journal for Quality in Healthcare Communications, and an expert at the ISQA for 2018 to 2023. And sir is a lead for National Mentoring Group and Technical Resource Group lead for Sustainable Model of Luxury at the Ministry of Health and Family Welfare, and a member of the Quality, Equity, Dignity Working Group at the Ministry of Health and Family Welfare. We welcome you, sir, and I invite you for your talk on spread of quality improvement in healthcare across South Asian subcontinent.
Thank you so much, Dr. Ashna. I will just be briefly sharing my screen. Thank you all the eminent panelists, my dear friends, colleagues from across South Asia, BMJ UK, and other partner organizations. It is a privilege to share with you the journey of quality improvement across Southeast Asia settings. So just give me a moment. I will just be starting the presentation and taking you on a photo journey. I've tried to collate some photographs so that I can share the journey. This is a journey of 6 years, and this journey has been basically started in the year 2015. So it is year 2021 right now, and we are moving back to year 2015. So just a sec. Yeah. Just a sec. Sorry for that mix-up. Okay. Okay. Yeah. So I will be briefly, like I mentioned, talking about the spread of quality improvement in healthcare across South Asia subcontinent. Well, to start with, I would just like to place a disclaimer here that introducing the concept of QI into healthcare systems of low and middle income economies is a challenging risk. And as all of you know, the journey of QI movement in South Asia has been fascinating with its fair share of twists and turns. Well, for us, I would just like to reiterate here that the journey started in the year 2015. And this journey started from Peter's visit to Kalavati Saran Children's Hospital and Lady Hardinge Medical College. And I'm very privileged that Peter, who's been heading the ISQA, is currently here with us today as a part of this panel. And Peter, this was in 2015 when you sensitized us. We were not at all aware of what quality improvement is. And this is a small session in my seminar room with my DM students and a select few founding members of this group who were sensitized to the concept of quality improvement. Now, subsequent to this, in the year 2015, you can see this sweet baby. This is a photograph of a baby taken in the district hospital of Shillong. We were approached by the government of Meghalaya to envisage about accrediting their special care neonatal units as a part of National Neonatology Forum exercise. And this was the time when we introduced the state of Meghalaya to the concept of quality improvement. Well, this was the initial foray. And then coming forward to Dr. Raina's team and WHO CRO, in the year 2016, a very successful 4-day regional workshop for improving quality of hospital care for maternal and newborn health was held in New Delhi, where 11 member nations were invited. And I happened to be, along with a core team of my friends from India, around 7-8 of us. And with some of the facilitators, you can see here, Nigel, Carl Bose, and some of the other facilitators, we were privileged to be a part of the initial group, which was introduced to the concept of quality improvement by WHO CRO in great detail. We went back to our medical college and we were lucky to continue to receive mentoring support. You can see Ankur and Nigel here along with the USAID SS team at that point of time. And this support continued in the year 2017 when our teams at Lady Hardinge Medical College started making a foray into quality improvement. Our nurses were involved into this. A lot of physical workshops were continued to be organized right across the country, and involvement of the community and active foray into quality improvement over 2017. Over 2018, the movement of breaking the hierarchies, you can see the ward IR, you can see the assistant professor, you can see the nursing in charge, junior nurses, and the community, as well as the professor of pediatrics sitting all together and discussing about quality improvement. We made a foray with Government of India, thanks to Dr. Dinesh Bashwal, Ministry of Health and Family Welfare, Madam Sumita Ghosh, Dr. Teja Ram, and all the other commissioners of health for Government of India. NQCN was requested to be on board and help in the rollout of implementation of quality improvement into the Lakshya program, which is the labor room quality improvement initiative of Government of India. This was the same time when a core group of undergraduate medical and nursing students got together and made a foray into quality improvement, which was later represented by WHO headquarters as Be the Change, the story of the Gen X of the quality improvement teams. And this was the pre-service teams, which I'm just mentioning. In the year 2019, well, there was a massive expansion of QI across India, and later I will tell you how it spilled over to the Southeast Asia region as well. There were creations of large pools of QI nurse mentors. There were district hospital on-site mentorings. The teams were assigned to district hospitals in remote, far-flung areas, often with support of UNICEF India, UNICEF field offices, various national health missions. Medical colleges on-site mentorings were started. Pre-service mentoring for undergraduate medical students were done. Pre-service nursing quality improvement was introduced in the state of Madhya Pradesh and other states. We also made a foray with the introduction of quality improvement to the ASHA facilitators in the state of Maharashtra. And this was supplemented in the year 2018, well before the pandemic came. We shifted to an online mode, and with offsite remote mentoring, we made a foray, and this started becoming a regular feature to cut down the cost and to make a greater connect. In service education, Ministry of Health and Family Welfare is continuing nursing education programs. 2 days were entirely dedicated to the quality improvement capacity building. Field staff of medical colleges were trained, and you can see here a nurse from the primary health center who's presenting her QI project, and this is the facilitator who is mentoring the entire teams, and there is a poster walkthrough which is happening in a rural medical college in Maharashtra. So this was something. Now, apart from this, I take you again to the story of Be the Change group, that is the MBBS and the nursing students collaborative. And this got featured in the WHO headquarters Global Quality of Care Network, and still there, the story of the next gen of quality improvement improvers. So we then subsequently understood that it is many hands and many organizations which will be required to partner and create, this movement and make it spread across the South Asian region and beyond the confines of the Indian subcontinent. We started partnering with a lot of state and national health missions in disseminating the knowledge, the capacity, and the on-site mentorings of quality improvement, including developing key resources for various national health missions. And here you can see the MD NHM of Rajasthan releasing a resource for comprehensive lactation management centers, which was developed in conjunction with the NHM. We partnered with the Indian Army, and I'm proud and privileged to share here the photograph of Lieutenant General Madhuri Kanitkar here, and the Armed Forces Medical College and Armed Forces Medical Services team, along with key colleagues who are here. And this partnering with the Indian Army introduced the concept of quality improvement in the Armed Forces Medical Services. We were privileged to be recognized as a technical partner for supporting the Lakshya initiative for Government of India. And under the guidance of Government of India in December 2019, just a month before the pandemic struck, there was a large partners forum, and I'm sure many of you were a part of this. Over 50 technical partners got together under a roof, reiterating their claim to spread quality improvement across the South Asia region. Now, these partnerships spread to Global Learning Lab and WHO headquarters. We started continuing to partner with the community remotely in developing high quality care. And this is a photograph of a community assisting us in developing a patient handout for improving their compliance to hand washing practices in Katni SNCU. We continue to support the quality improvement initiatives of Government of India as technical partners. And in the year 2020, as all of you know, the very successful, nearly exactly a year back, in the month of August 2020, the Honorable Union Health and Family Welfare Minister Shri Harshvardhan and our very own Professor V.K. Paul, member Niti Aayog, Government of India, declared the vibrant communities of practice, which was supported by key partner organizations. All of you are represented here today. World Health Organization, ISPA, BMJ, 3M, URC, Oxford University Hospitals, Astarika, Mahatma Gandhi Institute of Medical Sciences, etc. So with this vibrant communities of practice was launched. And this community of practice, friends, right through these three phases, the phase of adaptation, conceptualization, and the sustained engagement, as you can see, multiple activities through September 2020 to July 21 have been undertaken. And this ultimately over the years, that is from the year 2017 to 2021, it led to the development of a framework of implementation of quality improvement across the South Asian subcontinent. And there were 10 or 11 quality improvement implementation strategies which have been developed. And I'm very happy to share here that the inaugural issue as one of the key articles is sharing the journey and the development of this framework. And I'm sure it will make interesting reading how the quality improvement movement implemented and scaled up. This also led to development of certain implementation products with potential adaptation across India and South Asia, neonatal hypothermia products, late onset sepsis reduction bundles, care around the birth bundles, KMC adoption bundles, perinatal asphyxia reduction bundles, respectful maternity care and birth companion bundles, infection control and prevention bundles, and QI bundles for the ASHA workers. So these are some of the implementation bundles which have been created during this part of this journey. Some knowledge products with potential of co-production have also been developed, like Psychology of Change online course modules, Psychological Safety Prevention and Management of Healthcare Worker Burnout, QI in Perinatal Asphyxia and Hypothermia Prevention, in Sepsis Prevention and Management, and the EPOKI self-paced course on which Janvi Nilekani is going to just be talking shortly as I finish. The year 2021, my friends, saw the shift of this movement to South Asia. And we started with the quality improvement to South Asia, which started intensively focusing on the Southeast Asia region of WHO CRO from March to June. In March 2021, the focus country was Bangladesh. In May 2021, the focus country was Bhutan. And in June 2021, the focus country was Maldives. Now, POKIs across Southeast Asia, these countries have been introduced in that same meeting which I was sharing with you initially. Bangladesh, 25 districts supported by UNICEF, the examples were shared. Bhutan implementation across major hospitals, including the implementation of QI for nurses, has been shared. And in India, like I mentioned, the Lakshya initiative with NQCN and All India Institute of Medical Sciences has been prominently focused and shared using this platform. And in Maldives, the various initiatives of QI across major hospitals of Maldives has been shared. And across this region of South Asia, more than 600 health facility teams are using point of care quality improvement across various departments like emergency rooms, casualty, trauma care, cardiac and surgical sciences, besides maternal and neonatal domains. The full journey and the tracing of this can be accessed from this key WHO document, which has just been released. And it is up and about on the Communities of Practice website and also on the WHO CRO and WHO headquarter websites. You are referred to it for greater details. Now, taking forward this journey, just a day back, the entire Southeast Asia regions, the 11 member nations were invited to participate in a regional capacity building point of care quality improvement workshop session with designing of their key quality improvement projects. And here you can see a snapshot, the multi-country session, which was undertaken on 31st July and 1st August, just 2 days back. And this was a very successful session, and it saw the borders, melting away. The countries, the participants, the various teams, interacting, sharing their experiences, etc. And this South Asia capacity building and experience sharing has been the hallmark of our quality improvement journey in the year 2021. And finally, friends, today we have all got together to see the documentation and witness the live unveiling of the QI stories from the field with the release of this very special first South Asia edition of BMJ Open Quality. And like I always said, it would go incomplete if I don't acknowledge the support rendered by BMJ Publishing UK, BMJ South Asia, and from the technical support of WHO CRO and the financial support for this edition by UNICEF India Country Office and Government of India, Ministry of Health, and countless peer reviewers, my editorial board, and all the authors who have contributed to this phenomenal issue. So with this, I would just like to mention here that a journey of 1,000 miles begins with a simple step. And I'm sure that the seed of quality improvement revolution has been sown. And it's been 5 years. And I'm sure over the next 5 years, this is going to mature into a revolution in this area and bring down the neonatal maternal mortality and improve the patient satisfaction. Thank you so much.
Thank you so much, Vikram sir, for sharing that. I would now like to introduce Professor Vinod Paul sir. Sir is member Health Niti Aayog at Government of India, where he leads the health and nutrition verticals. Sir leads the Government of India's Coronavirus Health Experts Task Force. He is pivotal in formulating the Poshan Abhiyan and the Ayushman Bharat initiative. Sir is also the chairman of the Board of Governors of Medical Council of India and a pediatrician by training, and has been a faculty at the Department of Pediatrics, AIIMS, New Delhi, where he was heading the department. He was closely associated with India's health policy and programs in various roles for more than 4 decades, and has chaired the Technical Advisory Group on Women's and Children's Health for WHO CRO and co-chair of the board of the Partnership for Maternal, Newborn and Child Health. Sir is a fellow of all the 3 science academies of the country and a recipient of the Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research and the Public Health Champion Award. He is a globally recognized academic and public health exponent and was conferred the prestigious Ishan Dogramesi Family Health Foundation Prize by WHO at the 2018 World Health Assembly. Professor V.K. Paul sir has sent his best wishes for the launch, and since he is currently occupied with some emergency work in the ministry, I would request Professor Vikram Datta sir, guest editor, BMJ Open Quality South Asia Edition, to share the inaugural message on behalf of Professor V.K. Paul sir, member Niti Aayog.
Thank you so much, Dr. Ashna. On behalf of Professor V.K. Paul, member Niti Aayog, I have the privilege of reading Dr. Vinod Paul's message, which is the inaugural message for this edition. Sir mentions, more lives are lost annually due to poor quality of care compared to lack of access to care. This gap is evident in low and middle income countries like India. Poor quality of care is a significant bottleneck in our quest to achieve universal health coverage. Quality improvement, especially at the point of care, can address this concern. It can provide frontline teams with a simple tool that can be effectively used in resource-constrained settings to improve processes and outcomes of care. The Government of India strongly advocates for a greater synergy between various stakeholders so that all such efforts collectively improve the quality and experience of care. The flagship National Health Assurance Program, Ayushman Bharat, and Suman envisage delivering high-quality care to the most underprivileged citizens of the country. Various initiatives like Kayakalp, Laksh, that is Labor Room Quality Improvement Program, Mera Aspatal Feedback, and the National Quality Assurance Standards are additional steps in this direction. I'm happy to learn that the Nationwide Quality of Care Network, NQOCN, and BMJ Publishing are launching the first edition of the BMJ Open Quality Journal with the support of UNICEF India. The inaugural issue contains 20 diverse quality improvement stories from across the Indian subcontinent. This issue will serve as a key resource to share the learnings from the region with the larger global population. This special edition would encourage teams in South Asian settings to carry out QI initiatives at scale with longer sustenance phases with the active involvement of the community. The launch of a dedicated South Asia edition of BMJ Open Quality Journal will encourage teams in the region to document their learnings and share the same with the readers across countries. The editorial board and peer reviewers deserve to be congratulated for facilitating BMJ Open Quality South Asia Edition publication. This initiative will inspire countless healthcare providers and create ground for delivery of high quality care to the citizens of the region. Jai Hind. So, thank you so much, Dr. Ashna.
Thank
I
you,
think
sir.
we are indeed in deep gratitude of Professor Vinod Paul sir for blessing us with best wishes and showing us the way forward. And his leadership in this challenging times for the country is deeply regarded. This South Asia edition right now, friends, can be accessed online at the link which Dr. Ashna is just going to be pasting in the chat box, and it is live now. So we can just show the link, Dr. Ashna.
So I'll just be showing you.
Yeah. So you can all access this issue. This is, yeah. So this is, the issue is, it is going to be pasted in the chat box. The full issue is live now. And all the articles are open access. So we will just very quickly take you through a sneak preview of the articles in this issue and then move ahead. So we will just be turning the pages. So this is the first page. So this is followed by the table of the contents. These are the table of the contents with the 20 high quality articles. Next, please. So this is one of the editorials. Next. Followed by the development of the framework intervention strategies, which I was just mentioning. This followed by an article, which is the original research from All India Institute of Medical Sciences on strengthening sepsis care at a tertiary hospital, then reducing late onset neonatal sepsis in low birth weight neonates. Another original research on rationalizing oxygen usage in a level 2 special newborn care unit in Madhya Pradesh, India. A quality improvement report on antibiotic stewardship in a tertiary care NICU. A quality improvement report, which will make very interesting reading on implementing a 3-hourly feeding schedule in stable preterm infants. A quality improvement report on establishing the practice of birth companion in labor ward of a tertiary care center in India in the backdrop of the COVID pandemic. Another quality improvement report on increasing adherence to plotting of e-pantograph, very innovative study. A quality improvement report on rationalizing antibiotic use after low-risk vaginal deliveries in a hospital setting. A report on reducing healthcare-associated infections by improving compliance to ANTT technique in IV line maintenance. Use of point-of-care quality improvement methodology to improve the care around the birth. I think Professor Srivastava is going to be sharing this today briefly. And there's a quality improvement report on improving donor human milk collection in a hospital without a human milk bank. Again, very interesting reading. And a quality improvement report on ensuring administration of first dose of antibiotics within the golden hour of management in units with sepsis. A quality improvement report on advancing emergency airway management by reducing intubation time. And this is from All India Institute of Medical Sciences Emergency Department. A quality improvement report on the use of a checklist to aid young physicians in managing obstetric emergencies. A quality improvement initiative to decrease unindicated usage of antibiotics in NICU in Hyderabad. A quality improvement report again on increasing postpartum IUCD coverage through QI initiatives, a step towards reducing the unmet need of postpartum contraception. Very, very challenging area, very well addressed. Institution of Antibiotic Stewardship Program for Rationalizing Antibiotic Usage, a quality improvement project report. It is again one of the important reports from a rural medical college in Maharashtra. Next, please. And lastly, we come to the last part of this. This is the 20th article. This is a short report And this is very interesting, reducing congestion in the emergency driveway of a small hospital in New Delhi. So friends, I'm sure you will realize that point of care quality improvement or quality improvement methodology can find its usage or implementation not only in fixing clinical problems, but also fixing psychosocial issues, fixing social determinants of health issues, fixing practically every aspects of our life. So kindly access the full text version of this issue, and happy browsing to all of you. Thank you so much for giving me a patient hearing. We will now proceed with the rest of the part of the program. Thank you so much, Dr. Ashna.
Thank you so much, Professor Vikram sir. I now have the pleasure of introducing Dr. Neena Raina ma'am. Ma'am is Senior Advisor, Reproductive, Maternal, Newborn, Child and Adolescent and Aging at WHO Regional Office for Southeast Asia. She is working with WHO for the past 21 years and has worked as a coordinator for Health Through Life course and Regional Advisor, Child and Adolescent Health and Development. She's also worked in the government and non-government sector at senior levels before joining WHO and has more than 40 years of experience in the areas of reproductive, maternal, newborn, child and adolescent health, immunization, gender-based violence, and has published about 200 scientific articles in journals and chapters in books. Ma'am, I request you to speak on the importance of documenting progress to inspire self and others, the WHO Sierra perspective.
Thank you very much, Dr. Ashna. Professor Vikram Datta, who is a pioneer in the quality of care network, leading in India. Dr. Peter, Dr. Louis, my UN partner from UNICEF, Dr. Janet, Dr. Shumita Ghosh, who had to leave, and Professor Vinod Paul, who is being missed quite a lot. But I'm very pleased that he has sent a wonderful message. First of all, heartiest congratulations for the launch of this BMJ, quality journal, which is, so very important and is the need of the time. So I think I'd like to, first of all, thank Professor Vikram Datta for taking us through the journey, which is a photo journey. And those are good old memories during the non-COVID time. And I see that he has taken us through this journey, not only through the COVID times, but then non-COVID times it all started, but then not during the COVID pandemic, which has really taken a toll on everybody's life and affected millions of people. So my heart goes out to those, I think the gains which we made earlier to achieve our sustainable development goals in many countries because of the disruption of services to mothers, newborn children, adolescents, older people. I think a lot of gains have been lost. We can always get back to it. I think those who reach the facilities of any level must be provided quality of care. Quality is a concept. Quality is a habit. And I know that for earlier days, early, I would say 70s, when the institutional deliveries were very low in our part of the world, we were training traditional birth attendants to conduct deliveries. And we said, you wash your hands with soap and water. There were no gloves. And you just cut the cord with a clean razor blade and not with a rusted knife. That was quality for us at that time. Then you come to the hospital where there are gloves, there is a lot of, sanitization, there's a lot of, so the quality varies depending upon which circumstances a person is. But I always felt, and I think in 2015, when I launched in WHO CERO, the framework for quality improvement for reproductive, maternal, newborn, child, adolescent health, everyone was saying, what are you talking? The ministries were not so much convinced that, yes, this is an important area. And the most setback came from the doctors and the nurses who said, we are providing quality of care. What are you talking? What else do you want? But then I think the concept from quality improvement shifted to point of care quality improvement. And that is something which has really been picked up very well across the countries. And as Dr. Vikram Datta also mentioned, was very well accepted. So today we are together for BMJ Open Quality, South Asia edition launch. And you want me to speak on importance of documenting progress to inspire self and others. So I think there has been, when we were, I'm talking of 2014, 2015, when we started reviewing the literature, there were very few publications from our part of the world because nobody was really focusing. And even if they were focusing, I would say by chance on it, there was no systematic way to be able to address this kind of an issue and document it. So WHO CERO, as you know, has been supporting initiative on improving quality of care for RMNCH since the release of Regional Framework on Improving Quality of Care in 2015 to contribute to our goal to accelerate reduction in ending maternal newborn child mortality in the region. And my colleague who works with me in my team, Dr. Rajesh Mehta, has led this work very well in India and in other countries as well. I'm sure he must be connected to this forum. So the nationwide quality of care network, which Dr. Vikram Datta leads, and BMJ together have undertaken this initiative of producing BMJ Open Quality South Asia edition. And we are all here to acknowledge the launch of the first issue of BMJ Open Quality South Asia edition, which is providing a wonderful platform for many people who have been really wanting to publish the good work which they have done so far. So soon after this quality improvement framework which we introduced POCI, which is Point of Care Quality Improvement Model in the region, in collaboration with partners, and UNICEF has been our big partner, USAID has been our partner, and of course NQ, our nationwide quality of care network, Dr. Vikram Datta has really contributed immensely to this. So we have supported this capacity building of POCI through a series of regional and national trainings, including 2 days primary training of healthcare teams, followed by QI coaching to provide post-training support to them to sustain the practice of QI. I think sustainability becomes an important issue. Whatever you learn, if you don't practice, you tend to forget it over a period of time. And if there's nobody who can really monitor, encourage you, monitor to encourage, not to really discourage, but monitor you to encourage you to do better is extremely important. So by now, this POCI model has been introduced in all 11 countries of our Southeast Asia region and beyond, like countries in Africa, Uzbekistan, China. So there are a lot of countries which are learning from our region and moving forward. Partners like our WHO collaborating centers, AIMS, and NQOCN in India and other national institutions in other countries have greatly contributed to initiate, sustain, and scale up QI initiative now being practiced across all countries. The support of agencies like UNICEF, which I acknowledge tremendously, and USAID has been very, very important and extremely helpful. And I think that is very evident from the presentation Dr. Datta made. Without partnership, we cannot move forward. I think we walk up to a few miles alone, but then if you have partners like UNICEF, USAID, and many others which were mentioned by Dr. Datta, I think that the most important partner and the person or the agency which has to be in the driver's seat is the Ministry of Health themselves. There has to be a sense of ownership. And I think that's what has been able to take forward the initiative in India, because there is a tremendous ownership and support from the Ministry of Health and Family Welfare. So documentation of quality improvement practices is very, very important for capturing the changes implemented for quality improvement and accrued benefits at the health facility level, as well as for learning across QI teams widely. And based on such documentation, experience sharing is possible across QI teams that helps encourage adoption of good practices widely, encourage new teams, and sustain the motivation of QI practitioners. And I know that when you go to the ministries of health to advocate, and they said, show us some of the pilots in our country, don't show us the models which have been practiced in the Western world. So I think that's something which this journal is this open, quality edition is going to help us with this, that documents some experiences which can be game changers for many to adopt and to practice and to feel motivated to adopt and to take it forward. So publication of these QI projects and experiences in scientific journal is an effective way of wider experience sharing. And clinical leadership who have taken up QI initiative in their day-to-day work are particularly inclined to publications in peer-reviewed journals. And I'm very happy that it's not only RMNCH or newborn, maternal newborn care, but in this journal, there are quality improvement articles from other disciplines and other specialities from the hospital settings. And such publications of QI learning is sure way of leading for evidence-based transformation of policy and healthcare system. A special edition of Indian Pediatrics, I remember, was published in 2018 that had highlighted the need of investing quality improvement and conveyed basic principles and range of early experiences of application of POCI. And the recent literature search for the period of 2017 revealed that there have been 140 publications on QI in peer-reviewed journals from the region, out of which 90 were on use of POCI model, which is so encouraging. And as a result of continuous advocacy and champions like Dr. Vikram Datta and others who are present here, and I think I'm very, very happy to see all the champions connected today on this platform. Capacity building and publication. So advocacy, capacity building, publication. It is heartening to see that POCI and other QI approaches are getting adopted more and more in our region. I'm very happy, and it's commendable that NQOCN and BMJ have taken the initiative of producing South Asia edition of the BMJ Open Quality, the first issue of which is being launched today. The aim of this journal, I understand, is to publish high quality healthcare improvement work to serve as an embodiment for other facilities to inspire them and apprise them of quality improvement methodology. I also understand that the first issue showcase a range of 54 articles, which Dr. Datta mentioned, which have underwent a rigorous peer review process, which was efficiently supported by NQOCN. In the LMIC of South Asia, we need to build capacity in writing manuscripts that could be accepted by journals. This issue dedicated to South Asia have already provided good opportunity to create this capacity that NQOCN has considered, including in their work through the POCI community of practice. We believe that BMJ South Asia issue will serve as an important resource for the QI experiences from our region and reach the larger global audience. I congratulate and commend NQOCN who have created and contributed to this partnership and collaborating with BMJ for South Asia initiative. And we look forward to 2022 South Asia special edition and a greater participation from QI practitioner and experts across the country. And I wonder why we call it South Asia, why not Southeast Asia? And I think as WHO, we remain committed to support everyone who is going to take it forward. And we need champions to take this movement forward And as I said, quality is a concept, quality is a habit. And once you form a habit, it dies hard. And I think a documentation of the experiences itself motivates a lot of people in making sure that they are able to do the same thing in their own, area of work. So with these words, I would like to extend my heartiest congratulations to the team here and to Professor Datta and Peter and the BMJ experts and the leaders who are here and my colleagues from UNICEF and the ministry. Thank you very much. All the best.
Thank you so much, Neena ma'am, for those words. Next, we have with us Dr. Prashant Mishra, sir, who is Managing Director, India and South Asia at British Medical Journal. He sits on the steering committee of Global Academy of Medical Education in India and is a member of the Executive Council for the Association of Publishers in India. He's a subject matter expert for the Technical Resource Group under Lakshya Program of Ministry of Health and Family Welfare, focusing on one of the 5 strategic areas, that is potential areas of research under Lakshya. And he's extremely passionate about and works relentlessly towards improving healthcare outcomes in India. Sir, I now request you to talk about the BMJ South Asia and the NQC and POCI community of practice partnerships in furthering the cause of QI in the region.
Okay, thank you, Dr. Ashna, and thank you, NQOCA, for this opportunity. I'll keep it short. A lot has already been said, but the fact is really very delighted to see this day. And I'm equally worried that this wasn't easy for us. Neither I'm sure would have been easy for all the QI teams whose work has finally been published. This is not at all a mean feat, since BMJ Open Quality has quite high quality benchmarks. I'm equally aware that this mustn't have been easy for the NQOCN team, especially Dr. Vikram Datta and Dr. Sushil. If I recall, this started over a cup of coffee that I've had with Dr. Vikram almost, I think, 2 years back, if I'm not wrong. And I'd said that it would be so nice to see more QI work from India getting published, knowing that there is already so much happening in various parts of the country. This was then followed up by the Partners Forum meeting in New Delhi, which Dr. Datta mentioned, where the work of NQOCN with Ministry of Health and Family Welfare was showcased. And this was the tipping point, and the rest is all history now. Let me take this opportunity today to say my sincere thanks to the editorial board members, including Dr. Amit, Dr. Nigel, for their hard work and involvement for this special issue. A special mention for Dr. Helen Crisp, who's the editor-in-chief for BMJ Open Quality, who ultimately gave a sign-off for this project, and Janet, our publisher for the BMJ Open Quality. Now, having the vision and concept ready, we were ably supported by UNICEF as they funded this project. So grateful to UNICEF. Therefore, I want to express my thanks and gratitude to Luigi, the Chief of Health here in India. And at the same time, I want to acknowledge the kind support, encouragement, and contributions of different key stakeholders like Niti Aayog, especially Dr. Paul, for his guidance, mentorship, Ministry of Health and Family Welfare, WHO CRO office, who have all touched this project in some way or the other. I've been informed by Dr. Datta that this project will roll over to the next year, that they have already received the funding support from UNICEF for the next year. I believe this is a very important step for a sustained interest and momentum in this area of QI. I am pleased to see the QI work getting published in this particular issue, which revolves around the general theme of maternal and neonatal health, but equally pleased to see a mix of QI papers in the area of emergency medicine, cardiac care. I understand there have been 2 studies from AIIMS, the one on transport optimization from the Sitaram Bharti Institute, the papers on AMR, infection prevention, one on the framework development, one on the oxygen usage work at a district hospital. So it would be good to therefore broaden the scope of papers for the next issue. I sincerely hope the workshops which we delivered via the webinars, which we did last year to train the nurses on how to write and publish, one on the podcast development, and one on the QI itself would have helped the POCI community of practice. Here at BMJ, we'll be delighted to help and support further the larger cause of QI. In the end, I would like to remind us that QI and patient safety both are two topics very close to BMJ's heart, our vision, and I'm very happy to see some very good quality work getting published from India and the Southeast Asian region. I'm sure that as I speak, there are many more projects going on across the region, and I look forward to a continuous dialogue on this front. BMJ will continue to support the knowledge creation and dissemination for learnings to be shared and improvements seen across. With these few words, thank you very much.
Thank you so much, Prashant sir, for sharing those words. Next, we have with us Mr. Louis Diacono sir. Sir is Chief of Health Section at UNICEF India Country Office and a COVID-19 response coordinator for the UNICEF India office. Sir has worked for 20 years in the international development sector in Africa and Asia, including Angola, Mozambique, Sudan, Malawi, Zimbabwe, Rwanda, Cambodia, Philippines, and others. Sir has also worked at Liverpool School of Tropical Medicine at UNICEF Mozambique, at Save the Children, at Medicines Sans Frontiers. Sir strongly believes in partnership as a critical force for change and is fond of research and evaluation as a strong basis to form policy and practice. Sir, I request you to speak on the role of QI in creating optimized health systems during COVID-19, the UNICEF's perspective.
Right, good afternoon. Am I audible?
Yes, sir, you're audible.
Okay, so good afternoon, everybody. Again, I come after many, so a lot has been said. I can be brief, but I will not spare sharing my enthusiasm for seeing this coming through today, the launch at which we are all participating today. This is a milestone in a very important step. And Professor Vikram, you will remember over the last 2 years, every time we met, often over Sundays, there was always a recurrent point. We need not only to do, but also to share what we do. And there is no better way than such a great initiative. And thanks to BMJ as well for availing this to disseminate what's been done and to make this catalytic viral, to use a very common term in these days, sadly, so that others can learn in the region and also outside of the region. So I really want to congratulate again. The journey we have seen is amazing. The role of everybody, the leadership of WHO, the amazing energy and competence of NQOCN, the role, of course, of Ministry of Health, all other partners, professional associations, and now BMJ helping us documenting this is amazing. I hope that with these 54 submissions that mark the first edition are just a small start, and that with time we will not lose energy, but rather disseminate this platform and make it more and more something at which healthcare practitioners, managers, policymakers aspire to share their evidence going forward. So I would say, great day, but the journey really starts now. When it comes to system strengthening, what you see at my back is very, very colorful picture, which you can, it's probably hidden by my face, but this is the diagram that WHO has put forward for primary health care. And it has three colors, three big important concepts around primary health care, which is essential for universal health coverage. The blue one is multi-sectoral policy and action. So we need to look at the concept of quality from a multi-sectoral perspective, and we need the leadership, we need the guidance, we need the policies. I would say largely, and thanks for the words of Dr. Paul, of Dr. Ghosh, that we have these policies in the country. They are there, they're very well designed. So the real challenge for us is to getting them implemented. On the orange front, we need the involvement of people, the communities, their active engagement, their active participation. And this is critical, again, when we look at the issue of quality, to make sure that people express their perception of quality and are engaged from communities up to healthcare facilities in shaping the way services should work. And then down on the yellow, we have the services, the primary healthcare services. And I see a lot of the papers look at that aspect in particular. And there, we need it, it's been said, it's documented, it's published. We need it even more today, during the pandemic and during the crisis that the globe is facing. I believe that we need it even more for very, very simple reasons. We don't need to go into complex matters. Let's look at the demand. We have lost clients for RMNCH services. People are scared. The last place where you want to be probably in these days, if it's not for COVID, is a healthcare facility, because there is a fear of contracting the disease. Where does COVID come into play? Quality, sorry. Solid protocols, infection prevention and control, strong protocols readapted to the situation and communicated to the communities will indeed make it a reassuring point for women, for children to come to healthcare facilities for regular services. Let's look at the other side of the coin. Healthcare workers, from ushers to nurses, doctors, are entirely swamped, overwhelmed, overworked, and under an incredible pressure, which is physical and is also psychological. And therefore, also in that sense, maintaining simple but strict protocols and attitudes to ensuring minimum quality is also a safety measure, I believe, for healthcare workers themselves, to stick to some minimum points that should not be missed, regardless of the pressures that everybody is undergoing. So my 2 cents here are really about this. We needed this, and we have it before COVID. We need to see and look at examples of how the healthcare for women and children has been adapted, maintaining a strong framework of quality even during COVID-19. We cannot assume we will be out of this pandemic anytime soon. So we need to be sure to publish and to share good practices about how to ensure that from a home visit from a HASHA up to an SNCU, quality can be made. It can happen even under the conditions in which we are living today. And I think this will be essential going forward as an add-on. It has been said before by Dr. Nina and also by others about how we use this platform for disseminating the concept of quality in this particular context. Before I give you back the line, I just want to add one simple point, one additional piece of information. And again, thanking NQOCN for this. I think that this month in August, Dr. Vikram, please correct me if I'm wrong, but there is an initiative that NQOCN is leading on in collaboration with UNICEF about creating or sustaining awareness for psychological well-being and health of frontline health workers with a focus on nurses and midwives during the COVID-19 pandemic. I think this is not about publishing, this is about doing, but it's an excellent initiative that maybe will be published in the second edition, who knows. But I want to stress this because at the end of the day, and I will close it, at the center of the concept of quality or of the attitude of quality, there is people. And people in these days are under enormous stress, be it the clients, be it the providers of services, be it the policymakers or the managers. So we need to take care of people if quality needs to be sustained. And an initiative like this happening now on psychosocial well-being of healthcare workers is essential in this regard. I will stop it here, congratulate again everybody else on behalf of UNICEF, and thank you so much for making this happen. Over.
Thank you so much, Louisa, for those words. Now, to share the message on BMJ Open Quality South Asia edition, bringing QI stories for all from all. We have Dr. Helen Crisp, ma'am, who is Editor-in-Chief, BMJ Open Quality UK, an independent consultant at Crisp QI, and has previously worked as an Assistant Director of Research at the Health Foundation, Director of Accreditation Services and Consultancy at CHKS Accreditation Unit, London, UK. And her areas of expertise include patient safety, person-centered care, quality improvement methods, healthcare improvement research.
Hello, I'm Helen Crisp, Editor-in-Chief of BMJ Open Quality, and very pleased to join you virtually today to celebrate the launch of the first South Asia edition of BMJ Open Quality. We were very positive when approached to support this special edition to promote the QI work that is happening in South Asia and encourage further efforts in quality improvement in the region. We are an international journal and aspire to be truly global, yet we recognise that there are many factors which result in us publishing more papers from certain parts of the world than others, and initiatives such as this help to redress that balance. The mission of BMJ Open Quality is to provide a publishing venue for valuable information contained in robust quality improvement reports to be available to others. The sort of papers that don't fit for other journals as they're not clinical enough, not original enough, not researchy enough. Yet these reports are building up into a curated repository of experience, guidance and ideas for people wanting to improve the quality and safety of the care they provide. We aim to publish really useful information on QI work, which shows the way and enables others to learn from the work that has been done. We know that one of the enduring problems of quality improvement efforts in healthcare is that there are many local projects that are not able to disseminate their results and experience, and the opportunity to learn from these is lost. Therefore, I'm delighted that the BMJ Open Quality South Asia edition is bringing QI stories for all, from all, and making them available to a global readership. I join you in celebrating the achievements of the authors, editors, peer reviewers, associate editors, and the BMJ publishing team who've brought this to fruition. Thank you all very much.
Now we have with us Ms. Janet O'Flaherty, who has been working with BMJ since 1997 and since 2008 as publisher in BMJ's journal division with financial and strategic responsibility. Her publishing career started at the British Veterinarian Association, whose journals BMJ now publishes and for which she is the publisher. Previously, she's also worked in Canada at a small commercial medical publishing company, including holding the position of vice president. I invite you, ma'am, to speak about publishing in collaboration to bring about hidden QI stories.
Thank you very much. I'm delighted to be here. I really just echo what my colleagues have said, particularly Dr. Helen Crisp, who was a great support through this, and you know, we're very glad that she has worked closely with Professor Vikram and his editorial team to bring this issue to fruition. I'm not a QI expert, I'm not a healthcare professional, but I have been in publishing a very long time. And BMJ, I feel, is a leader in quality improvement. As I said, I've been at the company nearly 25 years, and ever since I've been there, we've had journals and events in quality improvement and patient safety. And I think this edition really is an extension of that work, and a really important one to bring the stories and learning from the South Asia region to South Asia and the rest of the world. I think it's very, very important that this work is published open access, that it's available to everybody. I think we were all delighted with the number of submissions that came in. It was a lot of hard work for Professor Vikram and his team, particularly in the middle of the dreadful pandemic. And I think it hit the height of the India second wave, but we got there on time. The work is amazing, and it's we were also delighted that it did go slightly beyond the maternal health care and obstetrics, and we look forward to building on that for the 2022 edition, and I'm sure we'll have a much bigger response and even bigger issues for next time. So thank you all, and again, very delighted to be here.
Janet, thank you so much officially on behalf of NQCN and my partners UNICEF India, WHO CRO. We recognize your immense contribution to bringing this edition to South Asia and your presence today at short notice. And thank you so much for the showcasing part and helping us at all steps of this journey in these challenging times. We deeply appreciate the association and look forward to even more enhanced and fruitful next edition with your support and guidance. Thank you.
Thank you so much. Next, we have Dr. Janvi Nilekani, who is founder and chairperson at Astrika, a Nilekani Philanthropies initiative. She's a development economist by training and now works in the field of maternal health. She has a background in academic research in environmental and development economics with a particular focus on air pollution. She's an alumna of Harvard, where she completed her PhD in public policy and has done her economics and international studies from Yale. I invite you, ma'am, to talk about using technology to scale up collaborative partnerships for improving maternal and newborn health.
Hi, thank you. Thank you so much. I know the topic I've been given is using technology. That is part of what we do at Astrika Foundation. But I would like to take this opportunity to talk a little bit broader as well. I will get to the tech part. So just to step back a little, what inspired my passion with QI, right? My pregnancy is what inspired in me such a passion to work on healthcare quality improvement. So when I was pregnant in 2016, I was a PhD student at Harvard at the time. As you said, I was doing my PhD in public policy. And I was very research and evidence oriented. I was actually living in Bangalore at the time because I was running a randomized controlled trial of 1,532 bus drivers across 7 districts of Karnataka, which was the topic of my Harvard dissertation. So, I was into research, I was into evidence, I was fully up to date on what the science had to say about what quality healthcare looked like for childbirth. And for me, pregnancy was such a shock because I could not find quality healthcare in Bangalore for childbirth anywhere, not even in the most expensive hospitals, it did not exist. Right? I mean, I can tell you a gazillion examples of where the Bangalore hospitals at the time were not, practicing QI or evidence-based medicine or high quality healthcare, but probably the most stark one was the WHO recommendation about, there should be no routine episiotomy for first-time mothers. I could not find a supportive doctor anywhere in all of Bangalore who agreed with me that first-time mothers should not have a routine episiotomy. And this was despite all the evidences and best practices, right? So the challenge at the time, I mean, it's amazing the work you guys are doing now, all of us are doing, but at least in 2016, I guess, there wasn't enough QI pressure, right? There wasn't enough pressure for India to focus on improving quality of healthcare. Even in the most expensive hospital, this really gets to me. It's one thing to have inexpensive poor quality care, but this is actually extremely expensive poor quality care. And something Dr. Meena Raina said earlier in the panel struck me that it's very true. The doctor said, we are giving you quality care. And I was just like, you are really not giving me quality care. So I went to my obstetrician with randomized controlled trials, with systemic guidelines, with all of the WHO recommendations, especially on episiotomies as well. And she said, and it was a very sincere response. She said, I hear you. I know that's the guideline, but it's different here. All that research was done on white women and you are Indian. So one reason I'm so excited to be here today, and thank you for inviting me, and it's such a pleasure to see these articles being published, see this journal launch, is that I think it's so critical to have research coming out of India, which is global quality standards of research. The inner researcher, PhD academic in me is delighted to be here, even though these days I don't do too much academic research myself personally. So So getting back to my story, so this is what really sparked me into being personally so passionate about improving healthcare and improving QI across India. But for me, it wasn't enough to just do it in one hospital. I mean, POQ is needed, but I wasn't satisfied with doing, launching an NGO or something which worked on this, because I also cared really deeply about how do you solve this challenge at scale. I've been very fortunate to be exposed to people constantly who think about scale. Because of my father, Mr. Nandan Nilekani, and because of the teams he works with and my mother works with, I was just surrounded at the time by people who were deeply thinking about scale. I was constantly exposed to the tools that were being developed, all the thinking that had been done to really think through how can you take a measure like you have 5 years to roll out Aadhaar to 800 million Indians, and how do you do it? How do you say you're going to affect 200 million school children and actually achieve 100 million school children to the Diksha platform that the government of India now runs? So I was surrounded by people who are thinking very deeply about the concept of Samaj, Sarkar, Bazaar. How can they come together? How can we collectively as a coalition address societal challenges at the scale that India needs, with speed? We can't let COVID let us give up on the SDG goals. Speed is of the essence. And how can we do it sustainably? It's not enough to say that there's a donor-driven program of QI here, or there's a government is pushing a system there, or like there's this one hospital which is being innovative. All of those things are critical. But to do health systems reform across the board, we need to build coalitions, we need to build partnerships, all the things we've been talking of today. So that's what I was thinking back in November of 2017 when all of this was going on in my head. So when I graduated from Harvard and finished my PhD in public policy, I told my advisors, I'm really sorry, but I just can't go into academia. I have to go and do this. And for that matter, I must say, I also left air pollution behind. I said, no, I have to go and work on public health. So I set up Astrika Foundation, which is, as you mentioned, a Nilekani Philanthropy initiative. It is supported by the philanthropic capital of my parents, Nandan and Rohini. And we really work on progress across the entire health system at scale, right? Scaling of QI in healthcare is what Astrika Foundation is about. So the topic you asked me was technology. Technology is very much part of that. Like, how do you scale? Technology is a big part of scaling. So one of the things we have already launched and which is currently live is our digital learning platform. It's currently called Astrika Sphere. We at Astrika Foundation are the technical partner for NQOCN. So NQOCN has a course on our Astrika learning management platform about point of care quality improvement. And I want to tell all of you, we as a foundation are hosting all of the costs, and Dr. Datta and his team have already created the content. That course is available. Any of you can go to sphere.astrika.org and log in and do a QI course. You can give it to anybody. And we have so many other courses there on RMC, on childcare. We're partnering with WHO. We're partnering with the White Ribbon Alliance, with Fernandez Foundation. So it's a true platform of a learning platform of free for users, up-to-date, best quality content on healthcare quality improvement. And we have more content coming all the time. So please do go there and check it out. That's the part about technology. But I do want to say that digital infrastructure, like the virtual learning platform that we currently are operating, is only a tool to scale. It's one part of it. So when we say Sphere, like a societal platform for healthcare, we mean a lot more. Right now, since we're just young and getting started, the priority has been the virtual learning management system, but we have a lot of other ideas in the pipeline. So digital infrastructure can definitely empower scale, but there are many other things that improve scale. Just simplifying the process of QI improves scale. I mean, globally, so, turning QI into a toolkit, like what Ariadne Labs has done, or what, the WHO's labor care guide, which is just the most beautiful piece of work to translate the intrapartum guidelines into something which you can implement. Those things are all also infrastructure. They may be process infrastructure, they may be, method infrastructure, but all of that is infrastructure which drives scale. I mean, investing dramatically in point of care QI, like all of you are doing here, is part of scale. Everything that the WHO Academy is putting out about really using adult learning science to improve quality improvement is amazing work. I can go on and on about what every exciting work is happening in quality improvement in healthcare, both in India and globally. So as both Dr. Vikram Datta and Dr. Neena Raina mentioned, and I think more of you, that partnerships and coalitions are just critical here. If we are really looking at health system reform, like systemic reform at scale, with speed, sustainable, embedded change, which is embedded in every ecosystem in India, at least, if not the world, the only way is for all of us to work together to build coalitions and to build partnerships. So I'm delighted to be here. We are so excited to partner with all of you in the upcoming years to really scale up quality improvement. We should be looking back when it's time for the SDG goals and feel that we collectively, as a coalition of committed partners, we succeeded. We should feel like we succeeded at the SDG goals, that we did it. We improved quality of care. I think sometimes one of our slogans is about improving access to 25 million women in 2025 and so forth. And I think many people think it's a slogan for Astika Foundation, but it's not a slogan, because Astika Foundation is an Lekini Philanthropies initiative. We don't just talk about scale, right? We do scale, we do Aadhaar, we do Diksha. 5 years is completely doable. The SDG goals are 10 years away, they're completely doable, and we have to commit to doing them. We may not achieve it, but we have to start out saying we are going to hit these goals by 2030, and we're delighted to work with all of you in the years ahead on this. Just to conclude, I wanted to talk a little about COVID. Something that Dr. Neena Raina said about how many gains have been lost due to COVID and the setback of the SDG goals. All of that is true, and it's often very sad to see it in real time. But I do want to also look at the bright side here. I think we have a real opportunity. The second wave of COVID has made the whole country understand the importance of health system reform. Now I think every individual doctor will understand why people talk about QI. It's to finish the Q and the I and then be ready for a third wave of the pandemic. You have to do health system reform beforehand, right? Not only in a minute of crisis. So what the crisis has done, I think, is really emphasize the value of health system reform and emphasize the value of QI to every stakeholder in the system, every stakeholder in Samaj, every stakeholder in Bazaar, and every stakeholder in Sarkar. So I think there's a real opportunity here in the next 5 to 10 years to make transformative levels of quality improvement in healthcare in India. So let's not let it lapse. Let's not see that COVID as such a setback or feel that the SDG goals aren't possible. Let's instead look at COVID as a catalyst, which unleashed a revolution in methods of how do you do QI at scale? How do you use digital means? How do you use innovative and fresh ways of thinking? They say that, necessity is the mother of invention. And that's kind of, I think, what has happened with COVID. I think we should see this crisis as an opportunity which has enabled true health system reform across India. Thank you.
Thank you so much, Dr. Janvi ma'am, for sharing those enlightening words. And for the next speaker, we have Dr. Peter Lackman, sir, who is Chief Executive Officer of ISQA and co-founder and chairperson of the Pediatric International Patient Safety and Quality Community. So is the lead international faculty at the RCPI in Dublin, where he co-directs the leadership and quality program to develop clinical leaders in quality improvement. So has developed the QI program at Great Ormond Street Hospital, where he was the Deputy Medical Director and lead for patient safety. Formerly, National Clinical Lead for Situation Awareness for Everyone, Royal College of Pediatrics and Child Health program to improve situation awareness in clinical terms. Sir, I request you to say a few words about the BMJ Open Quality South Asia edition.
Thank you for that introduction. So I've stepped down from the role at ISQA, so now I'm at the College of Physicians in Ireland. And I firstly want to thank you, Dr. Vikram Datta, for your kind words at the beginning. I remember coming to India in 2015, and from small ideas has grown really, the seed that was planted then has grown a big tree that's still growing and will grow further. The work that has happened over the last 6 years and culminating with this edition of the BMJ Open is testimony to leadership at all levels. And I want to congratulate everyone. I'm not going to pick up anyone. I know, Dr. Vikram, you have led from the front. but there are many others. All their names are over there. I must really say to you, from my perspective, one of the big problems worldwide is that people have looked to the upper income countries where quality improvement started for the solutions. And I've always said the solutions are not in the United States for India or other Southeast Asia countries, but are in Southeast Asia. That's where the solutions are. And actually, I think that people in the upper income countries could well do read all of the 50 articles, because then they will understand that quality improvement can be done with minimal resource, where the resource are the people. And that is what I've heard across the different speaks from UNICEF, WHO, BMJ, that we really have to focus on the people who are going to make the difference. As in our last speaker says, the people involve both the patients, the women, the children, and the providers of care. And together you can co-produce quality and safety. It's very apt that this edition has come out with a focus on maternal and neonatal health, because this is going to be the World Patient Safety Day theme this year for the WHO. So I really suggest that you send this out to the WHO team also in Geneva, because they can really promote this as part of the annual event, which is on the 17th of September. So I think you're ahead by a few weeks, and but this is something we shall celebrate on that day. I also want to thank all of those who have helped on the side by reviewing the papers, by making sure they get into publication, because it's so much so that often people doing quality improvement projects are not natural writers. They're not thinking about publication when they start. But I think now we have to say to them, there is an example that if you do a good project, you can have this published. And we need to get young doctors and nurses and people involved in this from the start. So this is leading the way by example. So there's so much I could say, but what I want to say, I am so proud of all of you for what you have done across the region. There's no words can say the achievement that has been made over the last 6 years to put quality improvement in one of the largest countries in the world at the forefront of what you do. And I think that now Southeast Asia region can be the leader in quality improvement. You don't need to say, what are they doing in the USA, Europe, and elsewhere? You can say, what are we doing in the region that we can learn from and spread and make lives better for all? As you heard, COVID has been a great challenge, but it's been the opportunity for us to look forward to how we want healthcare to be, not how healthcare was. So I congratulate you all. I look forward to the second edition. Hopefully I can help you on your way and make sure that the quality of care for the women, the babies, the children, the families, and for all going on in India and Southeast Asia region will continue to improve and see the fruits of all your work. Thank you very much and congratulations.
Thank you so much, Peter. I would like to take this opportunity to once again thank you. Like I just recounted in my journey earlier, the seed was sown for all of us in India by your visit in 2015. And I take this platform to, thank you once again, express our deep gratitude to the guidance and the tremendous support, even during your times as the CEO of ESQA and now in the Royal College. And definitely, I'm sure we will continue to receive the guidance and the support for the subsequent documentations, including some mentoring sessions from you, Peter, for our prospective authors over this year.
Yes, and just to say, something that I think you'll all experience is that I was privileged to be able to go to learn quality improvements in 2005 at IHI in the USA. And now in my later years of life, my job is to give back to the people. And I look forward to working with all of you in India and for hopefully visiting the region soon when we can, because I think that those of us who had the opportunity to learn, our job now is to work together and give back and to make a difference. So I look forward in the future. Thank you very much.
Thank you.
Thank you so much. Now, just to give a sneak peek to the issue, we have some authors who will be sharing short presentations of some papers from the issue. And first of all, we have Dr. Saru Bhatia, who works at Sitaram Bharti Institute of Science and Research, New Delhi, and she'll be sharing about a paper on rationalizing antibiotic use after low-risk vaginal deliveries in a hospital setting in India.
I think you have to unmute yourself.
Can they see the screen? Can you all see the screen?
Yeah, we can see the screen.
Wonderful. Before I start my presentation, I'd like to thank everybody at BMJ Quality and NQOCN for giving me the opportunity to share Sitaram Bhartia's quality work at this event. It was 2017 when our obstetrician encountered a case of post-op multi-drug resistance, which led to increased length of stay and a painful recovery for one of our patients. This incident compelled our team to introspect the appropriateness of antibiotic usage in our OBGYN department. We started with mothers with uncomplicated vaginal deliveries first because they had the lowest risk of infection. Case files of low-risk normal delivery mothers for 2017 were reviewed to understand the extent of the problem. Analysis revealed that the antibiotic usage in the subgroup ranged from 24% to 69%. The department felt the urgency to reduce antibiotic usage, and hence a team was formed to initiate a QI project. The team comprised of senior OBGYN consultant, attending consultants, and 2 quality executives. The aim of the team was to reduce the use of antibiotics in this subgroup from an average of 42% to less than 10% in a period of 4 months. Besides the outcome measure of measuring percentage use of antibiotics in this subgroup, we also measured percentage of women developing perineal infections and percentage of neonates contracting infections. This was done because of the concerns that our obstetricians had of not using antibiotics and leading to infections in women and neonates. So here's a list of change ideas that we implemented in this project. All these change ideas were tested through PDSA cycles. The team first met and decided the first change idea was to create a written departmental policy on use of antibiotics in this subgroup. Literature was reviewed and a policy was created against routine use of antibiotics in low-risk uncomplicated vaginal births with or without episiotomy. This month, that was February 18th, we saw an Hawthorne effect. The usage of antibiotics reduced to 16%. However, in March 18th, the subsequent month, the use of antibiotics again crept up. This time it was 31%. The team met again and decided that drafting a policy was not enough. They therefore planned regular meetings every 2 weeks. These meetings were planned to discuss progress and to consider any change in policy based on challenges faced by the obstetricians. The second idea came up in another meeting that happened in April. One of these meetings, the doctors shared their concern about infection in cases of anemia, postpartum hemorrhage, and few other nondescript clinical situations. To address these concerns, literature was reviewed and the policy was revised. In the same meeting, the quality executive shared concern over appropriate documentation of data in case records. The team decided to address this concern by making changes in the labor and delivery progress notes. A format was created with the help of the obstetricians, which would remind the obstetricians to write the reasons of the use of antibiotics in this subgroup. Well, with both these changes, we saw significant improvement, and a usage of antibiotics for the month of April came down to 5%. At this time, we faced a setback. Our clinical champion for this project left, but was replaced with another passionate champion who then came up with another idea. Having spent a month on the project and leading it, she recommended that there should be dual responsibility for antibiotic prescription. This meant that there should be an approval of 2 seniors in case there was any deviation from antibiotic policy. This was our last major intervention, and since then we have been tracking our progress. For the years of 2018, 19, and 2020, our antibiotic usage has been an average of 9%, a 6%, and 16% respectively. In 2020, the usage went up 16% to an average of 16% due to COVID-19. Due to COVID, we saw a shift in median from 8% to 21%. The pandemic led to a fear that other infections may supersede. We also found that the focus shifted to the COVID scenario. There were no regular patient follow-ups, and there were frequently less team meetings. Since the COVID numbers have reduced, we have improved on our compliance to the antibiotic policy. But by the time the COVID fell, till then, our antibiotic compliance was less than 10%. And this significantly is less than from where we started, which was 42%. This was a team effort, and everybody from our attending consultants to all our senior consultants, the quality executives, all have been working together to bring us where we are today. Going forward, we will attempt to rationalize antibiotic usage in instrumental deliveries, emergency, and elective C-sections. Thank you.
Thank you so much, Saru ma'am, for sharing that paper with us. The next paper is about the use of point-of-care quality improvement methodology to improve newborn care immediately after birth at a tertiary care teaching hospital in a resource-constrained setting by Dr. Sushil Srivastava sir, UCMS GTB Hospital, New Delhi.
I'll start my screen share. Just hold on.
Sure, sir.
Just give me 1 minute. Is my screen visible?
Yes, it's visible.
Okay, thank you. So, good afternoon, everyone. I'm going to present the article which has been published in this journal. Is use of the aim statement was use of point-of-care quality improvement methodology to improve newborn care immediately after birth at a tertiary care teaching hospital in a resource-constrained setting. Well, this quality improvement project was involving the immediate care around birth when the newborn is born, which includes skin-to-skin care, providing early initiation of breastfeeding, delayed cord clamping, and a pre-delivery counseling. The study or the project where the hospital where it was conducted is a public sector tertiary teaching hospital, where our annual delivery load is more than 20,000 deliveries. About 15,000 vaginal deliveries are being conducted at 2 delivery points, and the doctors and nurses on duty at these delivery points are on a rotation basis. And sadly, their rotation is quite variable depending on the availability of doctors and nurses. So the posting duration changes from 1 month to at times 2.5 months. Typically in a shift, there are about 3 to 4 nurses on a duty, and the average nurses on an average per day have to conduct or attend to 6 to 8 vaginal deliveries, including about attending to 10 to 15 expectant and post-delivered mothers, which are present in these delivery areas. So the challenge was pretty enormous. We were not able to implement the recommended WHO guidelines, evidence-based, which were 4 essential elements of care of birth. That was immediate and thorough drying, providing skin-to-skin care, delayed cord clamp, and early initiation of breastfeeding within 1 hour of birth. So this was a huge challenge for our team, and considering the workload and the repeated variability, the quality improvement team sat down and took up this challenge. The biggest bottleneck which we identified was how to translate these evidence-based interventions, which have been proven without doubt to benefit both mother and the newborn, into effective clinical practices. And the main bottlenecks which we saw was a high turnover of patients, shortage of healthcare providers with frequent changes in postings, and a lack of clear process definition. Now, this we found was surprisingly, even the process of providing skin-to-skin care has been so widely addressed in different literature, but exactly how to carry out this process, there are different takes on that. And that was the point of beginning for our team, as to we decided that we have to define each process clearly. We use the point of care quality improvement methodology, and for initial to start with, our quality improvement team consisted of 2 pediatricians, 2 obstetricians, senior nursing officers of the labor delivery points, and 2 nursing officers who were in the delivery area. Now, this was our basic rudimentary process flow for attending newborn deliveries. And as usual, and as has been the case in many other delivery areas for that matter, the process of immediate drying, skin-to-skin, delayed cord was actually not done and was hardly documented. People were knowing about what is immediate drying, what is skin-to-skin care, but they were not very sure how to carry it out and what to do. Similarly, initiation of breastfeeding after the baby was born should be done at 1 hour. Everybody agreed, and people tried to do that, but documentation and other parts were sadly far below expectation. This is what happened in last 6 to 8 months of intensive working with all the teams in different shifts, that we defined the whole process of care. The details of PDSs are there in the article, but I just wanted to highlight as an author to the esteemed audience here that we had a hybrid approach where we realized the importance of this simple 4-step point of care quality improvement methodology, which made us as a team to coordinate. And this coordination started with you can say introduction of mandatory pre-delivery counseling to mother. Now, with this pre-delivery counseling and briefing, which we did multiple PDSs, forced us, irrespective whether we liked or not, that the whole team present in the delivery room worked as a team. And that was very, very important for our variability. Second thing was clear procedure description and skill uniformity. Now, this was one of the most challenging PDSAs which we had. So, it continued to about 2 to 3 months, different teams trying different ideas. And finally, we could come up to a consensus that this would be the way by which we would be providing skin-to-skin care to all the normal newborn deliveries in the delivery areas, and how to dry, how to keep with the mother, how to continue skin-to-skin care despite mother being shifted from the delivery room to the observation room. So that clear description and process description was one of the most important key, you can say, PDSA change, which brought us to the easy replicability of our quality improvement initiative. And last but not the least, we also tried to innovate and contextualize the adaptation of these evidence-based guidelines. So yes, we did tweak a few guidelines which were there by WHO to suit our context and our team requirements, because the team was pretty hard pressed. Every time it was very difficult for them to stand by the mother and the baby, taking care of the skin-to-skin care. It is carried on for more than 1 to 2 hours. So a slight innovation, allowing the mother to carry on the skin-to-skin care in the observation area, empowering the birth companion or the attendant attending the mother to initiate the first breastfeed within 1 hour, and ensuring that it is being done was some of the key changes which we found could be replicated. And so we had these results within 6 months of our intervention. We had the median shifting from where we were not actually documenting all these 4 care points, and many times their application was also doubtful. We pushed up the median average rate to about 51% over last 3 years. Then similarly, delayed cord clamp, the median cumulative compliance in this delayed cord clamp was about 60%. Skin to skin care provision, median compliance rate in last 2 to 2.5 years is about 56%. And similarly, early initiation of breastfeeding was the median compliance rose to about 61%. The COVID year had been a big challenge for us. We were trying to, our hospital converted into COVID. So we are now rebooting again with our normal services and COVID going simultaneously, and we will be presenting this data subsequently. Now, the result of this, all this endeavor over 2000s, from 2017 to 2019 was a sustained compliance. And that was the biggest, you can say, satisfaction for our team, was which we initially we didn't think that it would be possible to sustain it, was a sustained compliance of about 50-55% of all those 4 care bundle points: pre-delivery counseling, skin-to-skin care, delayed cord clamp, and early initiation of breastfeeding within 1 hour. This was our cumulative data, which we had collated in last 3 years till 2019. In 2020, as I told you, we had only COVID deliveries, which were markedly restricted, less than 10% of what was our average annual load. And in those, our compliance was variable because of different guidelines being issued from time to time. So it was quite good for this project, for our hospital for that matter, because we had well-defined now standard operating protocols for pre-delivery counseling. We have a well-defined standard operating protocol for skin-to-skin care. We have a policy for delayed cord cut, and of course, a standard operating protocol for how to dry the baby on abdomen and continue the early initiation of breastfeeding. The limitations were majorly our shortage of manpower, which led to reorientation of new teams, still remaining a challenge because we have to reorient them again and again. The clinicians have to take out time and address these challenges as for reorienting other team members, as we do not have dedicated hospital managers or hospital quality inspectors or quality supervisors to continue this challenge, but the clinicians are continuing this job. We did not document routine newborn care processes in cesarean and in babies following or requiring resuscitation, which we are now planning to start post-COVID in our hospital. We also could not evaluate the short-term and the long-term impact of these care around bundle approach methods, which are definitely to produce a lot of benefits, which have been documented extensively in the literature, and we are planning another study to carry out these documentation. So what this study adds? Well, the implementation of the World Health Organization recommended evidence-based practices benefiting more than 10,000 mothers newborn diet annually over 2 years was the biggest satisfaction for us. Annually in 2018 and 2019, we could provide these bundle approach to about 10,000 mother and newborn diets, benefiting them. Implementation of evidence-based practice is possible in challenging situations using PDSA approach. Yes, this was a big, you can say, revelation for all our team members, that despite the challenges and the huge turnover, simple PDSA approach could contextualize and could help us in these contextualized processes to be convenient. They have a better success at sustainability and even in complex systems with resource constraints. So these were our main takeaways. As a conclusion, the improved process of care is feasible, scalable, and replicable in resource constrained settings. We are confident of that. We recommend that healthcare staff in labor room receive regular refresher training, essential newborn care, support, and breastfeeding. We realized that once in a blue moon or maybe 3 or 6 months training are not sufficient, considering the turnover of the manpower as well as the load. Monthly drills, in fact, are much better. We have just started these monthly drills and simulation in our NICU area. We are planning to do that, and we are planning to take it to our delivery points too, to ensure that the skills and hands-on remains as relevant as the newer staff comes into picture. Multi-dimensional approach is necessary to close the quality gaps, and in designing future programs for newborn care, that is very, very important. These are some few representative snaps of our teams trying to brainstorm, trying to motivate and get the root cause of our compliance variability. And yes, multi-stakeholders are very, very important. Thanks to Dr. Dinesh Baswal and the team at MOHFW, the Laksh program provided that necessary, you can say, push to our departmental leads to coordinate and collaborate and help us to deliver these challenging goals, for which we are really satisfied, and we are prepared to take this challenge, face this challenge to the next level. Thank you.
Thank you, sir, for sharing those insights from your paper. The next paper is on establishing the practice of birth companion in labor ward of a tertiary care center in India, a quality improvement initiative. And this will be presented by Dr. Aparna Sharma ma'am from AIIMS, New Delhi.
Can you hear me?
Yeah, we can hear you.
Yes. Hi. Very good evening to all of you, and a big congratulations, and really would like to thank Dr. Vikram Datta sir and NQCN for this amazing initiative. So I will just, talk about this particular project that we started, and I think this was one of our first projects to to be done in our labor room, and it was really a life-changing experience for us. We all know that birth companion is an evidence-based intervention, and somehow it was the mindset that no, we cannot allow birth companion in labor in the government hospitals. So it's absolutely not possible. But then when we actually went about to change this policy, we did have some hurdles, but then of course we went about it aided by the point of care quality improvement. So we aimed to establish the practice of allowing birth companion during labor in all eligible within 6 weeks. So this was started in January 2019, and our initial target was only, even up to 50%. So we had a group of enthusiastic team members, include data entry operator of our labor room, was also roped in, to have an idea of about what is happening. When we did an analysis, we realized that of course there was no policy or SOP. The other thing is that there was so much of resistance from people, among the staff, among the residents, that if they are present, there would be a problem. There is issue of privacy. If you allow one relative, process for counseling and identification of birth companion one by one. And our measure was to see how many births were accompanied by birth companion in the eligible patients, divided by the total number of eligible deliveries that were happening at the same time period. And we took vaginal deliveries because cesarean delivery, still we are trying to get at it, but I think it'll take time. So how we started is that we had a policy and sensitization of doctors. So the SOP was communicated to all, and there were regular meetings, and we talked about respectful maternity care, which was so important. A part of respectful maternity care is having a birth companion, and then ensuring that the partition by curtains does happen. So with all of these, in the first week, we saw that 25% of the deliveries were accompanied by the birth companion. Now, what we realized is, of course, that we have already learned so far in our QI journey is that telling people is not enough. Sensitization is not enough. There has to be little more than that. So the plan was to involve more laboring women and the family members and continued reinforcement. So there was a designated dress code. We had purple gowns which were designated, and we knew that, okay, that she is the birth companion. And there was counseling by the staff nurse at admission. More importantly, what we realized is that there is so much of resistance to birth companion from the relatives themselves. They don't understand the concept, and definitely that is where we planned our sustenance plan, that it is not enough to counseling during labor, and that is what we did. So there was a shift in midline, and of course we could do it a little more than 50%. And this particular thing was, again, we had WhatsApp groups where we would communicate more. Then there was, we initially started well, in the first and the second PDSAs, we were progressing well. There was some development, but then there were hurdles. So there was this enthusiastic team which started doing birth companion, and once the team changed, there was serious fall in numbers, and there were some administrative issues, including some of the issues with our senior professors, and some of the issues with our team members. So as is human, there is a serious fall in numbers. Then we looked into modification of SOP with consultation with senior faculty, and then the resensitization of the new labor ward team was
I think we lost the audio there. Dr. Aparna, we can't hear you.
or maybe 2 days before, when we actually, there is a changeover of labor room teams, we had a policy of giving over to the new team on all of the QI policy before we change over the team. And there we have realized that the implementation was much better. Despite challenges, sequential steps did help us in attaining our goal within the existing resources. So this is the time series chart, which really showed that after a serious fall in the initial 1 month, we could maintain a median of around 60 to 65%. Now, our goal is to actually birth companion, but with it was last year was a complete COVID year and everything went haywire. But then now we are planning on, and we are actually implementing structured antenatal counseling of women. So this was our learning, that counseling at the time of labor and delivery is not enough. So we have instituted a protocol for birth planning visit in all our antenatal patients, where they talk about having a birth companion, the characteristics of a birth companion, the do's and don'ts of a birth companion, much before they actually land up in the labor room. And also, with our new mother and child block coming up, we are making facilities for proper implementation of this project. So this was our first, or one of the very first QI projects that we have done, and we did face some major challenges, but by following simple steps of QI methodology along with a motivated team really helped us in achieving our goal. And till before COVID, birth companion was a common practice in labor room at AIIMS, which during COVID got a bit deranged, but we are coming back to normal, and we hope to come back to normal with a much, and also overall patient satisfaction, reduction of anxiety, and also initiation of the initial steps of newborn care. So I would like to thank our team, Dr. Juhi, Aprajita, and our labor room nurses, who really worked hard on taking this forward as a project. And sir, I would like to thank you again for this major and amazing initiative. And we do hope that our other projects are going to come out in your second edition very soon. Thank you so much. Thank you, sir.
Thank you so much, Dr. Aparna. I think we've just heard 3 phenomenal presentations from the authors themselves. For greater access to the wider array and the spectrum of articles in this issue, you are referred to the online issue, which is now hosted at the BMJ Open Quality webpage. The link is already posted by Dr. Ashna in the chat box. So do visit it and share it. It's all open access. And congratulations to all the authors. And we look forward to an exciting evening ahead. With this, I am pleased to call upon Dr. Nigel Lewisley. Dr. Nigel is the managing editor of this BMJ Open Quality South Asia edition. In fact, I would like to be sharing here the instrumental role, apart from Dr. Peter Lackman, who's here. It was Dr. Nigel Lewisley who's mentored most of the teams in the South Asia region as the USAID Assist South Asia chief at that point. And now over the years, from a professional to a personal relationship with NQCN and the entire South Asia teams, Dr. Nigel has extensively worked in over 19 countries. As you can see, he is one of the most sought after quality improvement coach globally. And we've had, the good fortune of having been mentored by Nigel and his team. And that's precisely like what Peter was saying, that having been mentored by IHI in 2005, well, we would say, Peter, 10 years after that, we were mentored by Peter and Nigel. And this is now our time to give back. But at the same time, we are still in the process of learning. And we will continue to learn from both of you and from all of us as a larger South Asia and a global platform. Thank you so much. So over to you, Nigel, sharing your experiences of this issue.
Great. Thanks very much, and congratulations to everybody. I think it's an amazing accomplishment. So many projects going on and so many being published. So congrats to everybody. And yeah, I think this is really important. As we've heard today, there's lots of problems with healthcare. We know what should happen, but it actually doesn't always get delivered to the people who need the services that they require. And the main reason behind that is because we sort of don't manage healthcare properly. A lot of healthcare systems imagine that if you have the right resources and if you have the right people with the right training, everything will just happen. And those are sufficient. They're necessary, but they're not sufficient. Healthcare is delivered by teams who need to learn how to work together. Individuals can't always change the things they need to change, so they have to work within a system. And that's been a challenge to convince ministries of health and international organizations that you need to go beyond providing resources and providing training. And people always ask, what is the evidence? And so articles like this, supplements like this are really the evidence. And you can't ask that question much longer because of the work that you guys are doing, which is amazing. And so I think there's two things that are really important about this supplement. First, that you have so many good results. And then second is that this was done without being driven by an international partner. I think there is quite a lot of QI work published from around the world, which is often driven with international money and international technical assistance. And that's not true with this supplement. This was clinicians in hospitals working independently with some support from NQOCN and from other groups. And there's been funding, obviously, from international partners, but it's there to support an indigenous mission, which is different. So I think this journal and this supplement is going to play a huge contribution. And it's very important, and I hope it continues. And so I think, I think three things would be good in the future. One, to keep doing this. One supplement is great. A second supplement would be better, and annual supplements would be even better. And to do them even better. Quality improvement is, it's something you can learn very quickly and get results very quickly, but you can get better results if you spend more time learning the skills better, learning new skills, and continuing to develop yourself and your team's ability. So I hope we keep seeing supplements like this and we keep seeing even better results. The second thing that I think would be important is, and this is more for the international partners, WHO and UNICEF and USAID and so on, is that, over the last few years, the words quality improvement have become less meaningful. Clinicians know what quality improvement means. It means working in a team to fix your problems. But a lot of international organizations now use quality improvement to mean anything. If you're doing a training, that's quality improvement. If you buy an incubator, that's quality improvement. And so the meaning is becoming less clear and less precise, which is a big challenge for good implementation work. If everything becomes quality improvement, then you will just stay in the status quo. And this movement that you're all part of is really going to struggle. So I think the international partners need to play a role in using the terms correctly and in being precise about this. And then I think the third thing is, someone was talking about this earlier, was scale. We need to think about how to change the entire health system, not just health facilities, but the larger system as well. And that's thinking about how to integrate quality improvement into different levels. What are the skills you need? How do different structures in ministries or large organizations need to change to support quality improvement? How do the other parts of the systems, finance, human resources, information technology, all of that, how do they need to change to support quality improvement? And the fourth, and probably the most important thing is, what are the cultural elements that need to change? A lot of health systems, really do focus on individuals, and they are quite punitive. It's hard to do good quality improvement work when you're just focusing on individuals and looking for someone to blame. So those cultural changes need to be made. And I know a lot of people are working on this. Sierra and Incluve Labs is working on guidance to do this. And hopefully that can be a focus for coming supplements as well, and something that we can all work on. So it's not just our hospitals that are doing well, it's the entire health system has an ability to manage better. But I think this supplement and the work you're doing is an incredible contribution to that. So congratulations to everybody. Thanks.
Thank you so much, Nigel, for those words and those guidances for the future editions as well as the future work in South Asian subcontinent. Thank you so much indeed. I have now the pleasure of welcoming Amit. Dr. Amit Gupta served as the Associate Editor UK for the BMJ Open Quality South Asia edition. Amit is the Clinical Director of Newborn Services at Oxford University Hospital, NHS Trust, Oxford, and a Clinical Lead NICU, John Radcliffe Hospital, Oxford, UK. Amit, over to you and your experiences of steering this edition to completion and final culmination.
Thank you very much. A lot what I wanted to say has been already spoken by speakers before me, especially by Nigel. So I'll keep it brief. I think, first of all, it's been a great privilege to be associated with this. And so thank you, Vikram. The journey has not been easy because you're starting something which has not been done before to this scale and to this kind of quality and this kind of rigor that is important. Nigel mentioned about the word quality being meaning different things for different people, and I think there is a risk for that. But having a journal and a supplement that comes out from South Asia, which has the kind of people who bring in that rigor, and it is something that will only improve with time, is a big first step. And that kind of visibility, the credibility that comes with this work will inspire a lot of other, a lot of quality projects to come in and join and contribute. We were having this discussion in the very beginning, and the worry that often is with such projects is that will we get enough people writing to us? Will we get enough papers being submitted? And we have enough and more than enough. But here's the prediction: this will only increase because this is not coming out of the blue. This is coming out of a background that NQCN has done over the past 5 to 7 years. Vikram talked about projects in Meghalaya and working with state institutions. So there is already a bedrock of quality improvement activity, which is there in the health consciousness of practitioners, and that is now going to that is now got a voice, and I would say that voice is only going to get amplified with time. So it's been a great thing. One other small point that I would like to mention is that having the ability to demonstrate improvement in a resource restricted, constrained, both from the resource, from institutional habits and practices and the cultures that we operate in, and to show improvement and to show a real and clear evidence-based improvement in outcomes is a huge morale booster. I think it brings in a lot of hope. And I think that's very important. And so a lot of the projects that people will see in the supplement are done with such ingenuity and with such cleverness and innovation that itself will inspire a lot of people to take part in this. And secondly, one final thing I would say, what Nigel has mentioned, is that I have no doubt that it will start influencing policy on an institutional level. And this is very important because policymakers need to see through quality improvement where quality improvement projects can be supported. And this is very important. I read somewhere that from the point of evidence to actual implementation, often it takes 6 to 10 years. And it astounded me. And that's because, as Nigel has mentioned, we are humans and we operate in human systems. And you just have to understand that the real world operates very different from the research world. And bringing that kind of knowledge and bringing that kind of rigor in quality improvement projects is going to provide that evidential base that we need. So that's all I had to say, but thank you for having me. Thank you for making me part of this journey.
Thank you so much, Amit. I think this session would not be complete if I do not express my gratitude to my associate editors, Dr. Naveen Jain, Dr. Vishwas Sapola, and Dr. Sushil Sharvastav. Besides Amit and Nigel, and Ajit Sutke, a very close friend, and associate editors, who together looked at this issue and brought it to the final culmination point. Thank you so much. Please continue to spare your valuable time in steering the next edition as well. And over to you, Dr. Ashna. Thank you so much.